Am I audible? Alright. So very good evening to all of you. Welcome to this session at DocTutorials, that is Clinical Thursday. So friends, it's a wonderful initiative by DocTutorials where each of us, all the 19 faculties will come every Thursday, will meet you and will discuss one important clinical case that we expect in our upcoming exam. So, hello, yeah. So friends, we want to prepare you for the next examination where we'll have more of integrated questions, where we'll have more of clinical questions. That is what we are expecting. So this is one initiative where we are trying to take all the important clinical topics and we'll come to you live and we can discuss one by one all the topics. So a very welcome to all of you from my side. I'm Dr. Shivani Jain, Ophthalmology faculty at DocTutorials. So guys, we can be connected at various platforms, as you know that there's an Instagram channel and there's a Telegram channel as well. So I'm sure that you are doing great, everyone. All of you are preparing well for your upcoming exam. All right. Chalo bache, without wasting time, let's jump on to our clinical question. So that appears to be a big, huge one, and that is the demand of the hour. Guys, we should be in a habit to read such big, huge questions as well, isn't it? So chalo, let us start reading the question. So it says that a 50-year-old female went to a physician complaining of frequent headaches and heaviness. Okay, so it's complaining of frequent headaches and heaviness of half of the head since a month. Also, she describes that she sees ring of halos around the light. Okay, the last episode she tells was when she went to see a movie in theater and she developed a similar kind of headache and pain in the eye. And now something about her personal history. She is a school principal and she used glasses since many years. Okay, so she used glasses. Now she has a hypertension as well. She is being on treatment for this hypertension. There's no other systemic or drug history. But on examination, her BP today was absolutely normal. It's 120 by 80 and she was referred to you in the eye OPD for the same. So she has what? A headache, eye pain, and she sees some ring of colors around the light. Now when you did examination, you found that there's an early cortical cataract in both eyes with a vision absolutely normal with glasses. Okay, so she used some glasses by which the vision is normal. Now her IOP is 24 millimeters of mercury on GAT. What is GAT? Goldman applanation tonometry. The central corneal thickness is 510. So what is your next step of management, guys? How should you manage the case? So any answers, first of all, reading the question? Any answers? I'm just highlighting to you what are the important clues which make you diagnose that this is a case of something related to angle closure glaucoma. Yes or no? I'm just highlighting those points. So what are these? This is something about a 50-year-old female. Okay, female. So headache, heaviness, colored halos. I think you can make it out that ring of colors around light. She is mentioning about the colored halos. Okay, and there is some repeated episodes as well. Okay, repeated episodes. Now she has been on some glasses. Okay, now there is history of glasses also. And when you saw, there is a hypermetropia. I'm sure that you can make out plus 2 glasses is nothing but here a hypermetropia. Yes or no? There's a hypermetropia. So now can anybody tell me what should be the answer here? Anyone, what should be the answer? You can easily correlate that today we have a discussion on angle closure glaucoma. So we are talking about the same. So will you start anti-glaucoma drugs? Will you do a gonioscopy and YAG-PI? Or you'll continue further with the investigations, visual field analysis will be done and you treat her for migraine. What is it? So migraine can also present like that, isn't it? Females, colored halos, headaches, you can have migraine as well. So anyone, what should be the answer here? So the correct answer here should be a gonioscopy and YAG-PI. Surprising for many of you, I guess. Is it? Okay, so this is the correct answer. So let us now speak something very, very brief about glaucoma. Okay, glaucoma today is not the whole topic. Today we will be fixing on angle closure glaucoma only. Okay, so just to mention something important, as you know, glaucoma is a triad. When you have a high IOP, there is optic neuropathy and there is visual field changes as well. But guys, what is the modern definition of glaucoma? The modern day definition of glaucoma says that it's a group of disorders, right? And there is a chronic progressive optic neuropathy, there is a damage to the optic nerve, and simultaneously you have visual field changes. It does not mention about high IOP at all. Okay, please see, this is the modern day definition of glaucoma. Now I am sure that you also know that what is the basic mechanism of glaucoma. There is a mechanical theory, there is a vascular theory. So here increased IOP is the main factor, but here even in the presence of normal IOP you can also have a glaucoma. Okay, so these two are the important theories. Now guys, if I just mention you a very simplified definition of glaucoma, very simplified classification, I can just say that you have an open angle mechanism, closed angle, and a congenital glaucoma. So we all know that. Now guys, if you are just familiar with the route of drainage of aqueous, you are knowing that there are two types of drainage. The one is trabecular outflow. So how is this trabecular outflow? Let us just concentrate ourselves on this picture. What is trabecular outflow? It starts from here, goes through the pupil, goes through the trabecular meshwork, gets absorbed. This is your trabecular outflow. What about the other one? The other one is when it starts from here, go through the pupil to the anterior chamber, it goes back to the sclera and gets absorbed here, isn't it? So this is your trabecular outflow and uveoscleral outflow. Alright friends. Now guys, what happens in angle closure glaucoma? So that is a picture where we are depicting you how angle closure glaucoma occurs. What is the mechanism of angle closure glaucoma? So let us see first of all what are the risk factors here friends. What are the risk factors? So friends, risk factors is a very important slide. You must know that it generally occurs within 45 to 60 years of age. Females are more commonly affected, almost 3 to 4 times more than males. Okay, females much more affected, and these two are matching with our patient. She is a female and she is middle aged. She's like 50 years of age, isn't it? So demography profile we have in our question, right? Now, what are the anatomically predisposed eyes? What do you mean by this anatomically predisposed eye? So guys, people who have a small eye, a shallow anterior chamber, a small cornea, a hypermetropic refractive error, but a normal or a large size lens. So everything is small. Remember, everything is small, but what is normal or large? Lens. Remember, this is important. So guys, whenever you have such kind of risk factors, what happens? Let us see. I am sure that you can make out there is an anterior segment crowding. Can you see? Anterior segment is very crowded here, isn't it? So because of this crowding, what happens? Whenever you have predisposing factors, what are those predisposing factors guys? These are the precipitating factors, the factors which bring about a mid dilated pupil, है ना? तो जब भी कभी mid dilated pupil आएगा, whenever you will have a mid dilated pupil, like when you go to a dark room, when you go to theaters, when you are emotional, because when you are emotional you will have a dilated pupil. Dilated pupil is sympathetic nerves, right? Similarly, when you have some kind of drugs like,
I didn't get that. Could you try again?
Like your atropine like drugs, isn't it? Sympathomimetic drugs. Whenever you have this kind of drug history, dark room, emotional factors, whenever you have this kind of thing, you may have a precipitation of the angle closure glaucoma attack. So let us see what goes wrong. So guys, whenever you have such kind of risk factors with precipitating factors, the iris and lens, they touch. Now when they are in contact, what will happen? The aqueous will keep all collecting here. Aqueous gets collected here. Aqueous is not able to move out. Aqueous gets collected here. Now when enough aqueous collects, it will push the iris forwards. It's going to push the iris forwards. Where? Towards the cornea. And hence you have problem within the angle. So can I say the primary problem was at the pupil. There is first a pupillary block. Iris and lens touch each other and there is a pupillary block, right? Now what is the second problem? The second problem is at the angle, okay? So this triggers the angle closure glaucoma attack. Okay, you have a time when your IOP becomes very high. So this is your angle closure glaucoma. So this happens characteristically, guys, when you go to a movie, isn't it? Dark room, theaters, emotional factors, right? So this is a particular area where females mainly they come to you with a high IOP. Now again, guys, when this happens repeatedly, when this is happening continuously after every few days, what will happen? It will become long standing, and when you have long standing changes, there will be a synec formation, there will be adhesion. So when you have adhesion, there is a synechial type of angle closure. Okay guys, I hope you've understood the mechanism here. Is the mechanism clear to everyone? Friends, please let me know. So myopes, congratulations, congratulations. You can never have an attack of angle closure glaucoma because you are myopes. A history of glasses does not only mean that you have a myopia. A history of glasses may also, it signifies that you may have a hypermetropia as well. So this was a risk factor in our patient. Okay, let us now go back quickly to our patient. Let us see, are we matching, are we having those kind of risk factors? So we have the female, yes, and there is a history of hypermetropia. There is a +2 glass. Okay, so definitely some kind of precipitating factor is there. Now let us jump on to the symptoms of angle closure. Okay, so friends, let us talk about our patient. What was she having? She was having repeated bouts of headache, unilateral eye pain, unilateral headache, right? And she also sees colored halo. So this is very very typical of angle closure subacute stage. Okay, subacute as in, what do you mean by subacute here? Subacute means where you'll have spontaneous resolution of attack. There is a day when you have this kind of high IOP and it spontaneously will resolve. How? When you sleep. Why sleep? Anyone, why sleep? So sleep induced meiosis. Okay, so when you sleep, there is a meiosis, and when your pupil becomes constricted, what will happen? There will be no mid-dilated pupil, and hence the drainage will be opened. Have you understood this? So remember the subacute stage. Maybe our female patient is in the subacute stage because when she came to me, she was asymptomatic. That means the attack has been aborted. Okay, so she can present to you with a brow ache, there may be pain in the eye, there may be a history of colored halos at the same time. So guys, why colored halos? Why? So this is because of the corneal edema. Okay, so why corneal edema? Cornea में पानी क्यों भर जाएगा? Why there will be a edema in the cornea? So friends, when you have a high IOP, a sudden onset of acute rise of IOP, what will happen? The endothelial pump of the cornea, it fails. Temporarily, it fails. Now, when it fails, it imbibes fluid. When it imbibes fluid, the cornea becomes edematous. And because of this edema, the patient will see colored halos. There is a prismatic effect and the patient will see colored halos, right? And obviously, when there is a corneal edema, it will also lead eventually to a blurring of vision. So again, what are the symptoms of this subacute stage? You will have a painful decrease in vision. There will be a corneal haze, colored halos, and spontaneous resolution of attack will be there. Okay, patient will say कि मेरे को attack आ रहे थे, मेरे को ऐसे problem हो रहा था, but it resolved after some time. Okay, now guys, here is a very very important question. So what are the symptoms of acute congestive glaucoma? What do you mean by acute congestive glaucoma? So this is nothing but acute primary angle closure. Okay, according to the new terminology, it is also called as acute primary angle closure. Right friends, so this is a basically congestive attack where your pressure becomes very very high. Go brighter as mean Dr. Idhavatu. Brighter as in, should I use a brighter ink as in black color? That's what you want to say? Or my picture is not clear? Please let me know what was the problem, or the problem is at my end, the writing, the ink. Okay. So again, I'm telling you what is the difference between a Hanji, what is go brighter? Pen? The ink you meant? Is this now okay? Chalo. So there's a difference between a subacute stage and a proper acute congestive glaucoma attack. Attack here we mean that this will not be aborted on its own. So the patient will have a sudden very high rise of IOP. It may reach up to 60 millimeters of mercury. So the patient will be in deep trouble. There will be a PVR change. What is PVR? Painful decrease in vision with a redness of eye. Okay. She'll complain of a severe headache, nausea, vomiting. The pain may radiate to the jaw also. Alright friends, so this is something which you must know. What is the difference here? Now guys, how will I identify the patient? Okay, because there are so many conditions where we'll have PVR change. Okay, now how will I see? So eyelids will be little swollen. Okay, there is an inflammation, there is an edema, so eyelids will be slightly swollen. As you can see this patient, there will be a congestion. Cornea, conjunctiva, there will be a lot of congestion. It will become red. So cornea ko kya hoga? Cornea will become hazy, isn't it? Cornea will become edematous, cornea will be hazy. Now what about anterior chamber? We expect the anterior chamber is absolutely very shallow. That's why the patient has an attack. Now this is a very important question. So what will happen to pupil? Guys, sometimes it's difficult to diagnose the subacute stage of glaucoma with uveitis. Okay, because uveitic patients may also present to you with a high IOP. They can have inflammation, high IOP ho sakta hai. So how will you distinguish a early angle closure from uveitis? So this will be the diagnostic feature. How? So pupils here will be vertically oval, okay, mid dilated, and it will not be reacted. You can call this a fixed pupil. So this is the one, a fixed pupil, a mid dilated, vertically oval and a fixed pupil. What do you expect in IOP? IOP will become very high. It may reach up to 60 millimeters of mercury. Now what about gonioscopy? So guys, what is gonioscopy? You know that gonioscopy is an investigation by which we can identify the structures of the angle. That is, I can see till Schwalbe's line. That's the mnemonic we see on gonioscopy. We see iris, ciliary body, scleral spur, trabecular meshwork and Schwalbe's line. As these line represents the structure on gonioscopy. So when I say that I can't see many lines, that means my angle is closed or potentially closed, right? When I see almost all lines, I say the angle is open, isn't it? So that is the information we expect in gonioscopy in our patient, that the angle is closed on gonioscopy. Now, how can you assess the angle the other ways? So guys, this is one very important expected question in your exams. This is called as von Erich's grading. Von Erich's. So friends, in von Erich's grade, what do you assess? You actually assess the peripheral anterior chamber depth. Peripheral. Okay, so we make a slit at the periphery of the cornea, and this is the corneal thickness. So we compare this corneal thickness with the thickness or the gap between this. Okay, so corneal thickness is compared with the PACD. Now if you see, both of them are almost similar. We say it is grade 4 and your anterior chamber is not shallow, your anterior chamber is deep. Okay, not much details are required because they haven't asked you this question yet, but they can give you a picture question. They can ask you what are we assessing or which type of grading is this. So remember, this is called as von Erich's grading. It is very easy to do because we don't require any other instrument. We just require a slit lamp. So on slit lamp, make a slit in the peripheral part of the cornea, compare the thickness of the peripheral cornea with the peripheral anterior chamber depth. Okay, so that is all you have to remember. Now a very simple examination is with a torchlight. Okay, you throw a torch of light, and if your nasal iris is also illuminated, that means your anterior chamber is nicely deepened. But if not, that means there is a shadowing. This is also your eclipse sign. You show a torch of light here, and if you see eclipse, that means your anterior chamber is shallow. Okay, so these are 3 investigations by which you can clinically determine that your angle is narrow or angle is occludable or angle is closed. Okay, now what are the other signs? So guys, Unlike open angle glaucoma, we don't have cupping here. We have rather a congestion of the optic disc. This will become, slightly large. You can confuse this with early papilledema as well. Okay? Now here is an important question. What about this fellow eye? What do you mean by the fellow eye? तो दोस्तों अटैक इसमें आया, प्रॉब्लम इसमें हुई, तो दिस विल बी कॉल्ड एज फेलो आई विच इज़ asymptomatic. Fellow eye means asymptomatic eye of the other eye of the patient, right? So what do you expect in fellow eye? Anyone? So I expect the fellow eye will also have a shallow anterior chamber, isn't it? It will have a shallow anterior chamber. And can I say occludable angles on gonioscopy? If I do gonioscopy of the other eye, I'll see that the angle is almost narrow, very narrow, maybe angle is closed. Okay, so this is called as fellow eye, but symptoms are not there. ठीक है बेटा? So fellow eye is the other eye, but symptoms are not there. Why I am stressing upon fellow eye? Because in our answer, in our question, we have done gonioscopy followed by PI of both eyes. That's why I am stressing upon the word fellow eye. What do you mean by fellow eye? ठीक है बच्चे? So we have discussed the symptoms, we have discussed the signs, how to see the angle is closed. Now my question to you, homework for you. So how do you assess the anterior chamber depth by 2 new investigation methods? Okay, so this is the homework for you. You have to mention in the chat box. If you know it today, very, very good. You have to mention it today. Otherwise, take it as a homework. How do you measure the anterior chamber depth? Are there 2 new investigations? So if you are a DocTutorials subscriber, we have discussed the topic of investigations in our app. It's a wonderfully covered topic where I have given you some new investigation methods also in ophthalmology. So both of them are discussed there. Alright guys, so if you are a subscriber, go to the topic of investigations and read from it. One question I expect in your next year exam, okay? So this is the one. Dr. Haswati, hi. Now guys, why I am mentioning Goldman application tonometry here? Because I want to tell you something very important as an expected question. So friends, Goldman application tonometer, you know it's a gold standard. It measures the IOP the best, but we have some sources of error. So we can have a high IOP measured or a falsely low IOP measured. Now what I am trying to say here is that if you have a thin cornea, suppose किसी का cornea thin है, if you have a thin cornea, what will happen? Whatever you measure in your patient will be slightly low. Now why I am telling you this? Because in our patient, let's go back to our patient. In our patient, if you remember, the CCT is 510 and the measured IOP is 24. So what I want to tell you is that if your CCT is less, suppose it's very less, it's 450. Suppose it's less, it's 480. So what will happen? Whatever you have calculated here is a false low value. So you have to correct it again. Alright friends? समझ आया question what I am trying to say? Here the central corneal thickness is absolutely normal. So whatever we have calculated on GAT is okay. But suppose I say that here the CCT is less, it's 450. तो जो हमने कैलकुलेट किया है वो कम कैलकुलेट किया है. वी हैव टू ऐड समथिंग. ओके डॉक्टर स्वाति, ठीक है बच्चे? मैम TPS कैन कॉट डीप एंड TPS क्या बच्चे? व्हाट इज TPS? आई डिडंट गेट यू. व्हाट इज TPS? मेरे को दिख भी नहीं रहा. टोटल पोस्टीरियर साइने के यू विश टू से? यस, टोटल पोस्टीरियर साइने के ग्लॉकोमा में होते ही नहीं है. यू हैव दिस इन सीवियर यूवियाइटिस. Okay Dr. Maurya, I think you're confused between two things here. Total posterior synechia, that is your plastered iris with your lens. This will definitely cause a deep anterior chamber. But don't confuse here. We are talking about a hypermetropic eye. हम एक hypermetropic eye की बात करें जिसमें पहले से ही सब छोटा है बेटा. पहले से ही anterior chamber is narrow. Are you able to make out the difference here, Dr. Ayush? हाँ जी. Alright, show me a thumbs up beta if you've understood. I want that your concepts should be clear. ठीक है बच्चे? Very good. चलो good. Now again going back to the question. So we have discussed the symptoms, the signs and how to identify. I've given you a homework also. नाउ ये आया है सबसे इम्पॉर्टेंट स्लाइड आपके INICT के लिए नेक्स्ट टाइम, ओके सर फ्रेंड्स. सो ये क्या है? सो दोस्तों, वट एवर आई हैव बीन टेलिंग यू, द सब एक्यूट स्टेज, द अक्यूट स्टेज, द क्रॉनिक स्टेज, आजकल क्लिनिकली वी आर नॉट यूजिंग इट. We are not using clinically these stages. So this is a classification given by American Academy of Ophthalmology. So it says that we divide angle closure into 3 types. One is the suspect stage, next is primary angle closure, and the next one is glaucoma. Now why? ऐसा क्यों किया है बेटा? ऐसा इसीलिए किया है because they want to give a unified definition of glaucoma. So they want to say that you can say it primary angle closure glaucoma only and only when you have optic nerve change, you have visual field defects. समझ आया? Otherwise what we have been observing that in acute angle closure optic neuropathy doesn't occur, है ना. We have not given a mention of that, rather we say the disc is congested, है ना, ये बोला है. तो वो कह रहे हैं कि ग्लोकोमा आप नाम तभी लो, you take the name of glaucoma only and only when you have a chronic change, when you have optic nerve change, when you have damage of ganglion cells, when you have visual field defect. So that is what they want to classify glaucoma as a unified thing, just for the maintenance of the definition they have told. Now अब इसमें पढ़ना क्या है? अब इसमें पढ़ने का important चीज़ है बच्चे ये. So suspect is basically a gonioscopic definition. Patient may not have any symptoms. पेशेंट को कोई सिम्टम नहीं है, बट गोनियोस्कोपी आप कर रहे हो, आपको लग रहा है कि सब कुछ बंद है. सो यू कैन कॉल इट अ सस्पेक्ट. नाउ लेट्स टॉक अबाउट एंगल क्लोजर. अपार्ट फ्रॉम अ वेरी शैलो एंटीरियर चेम्बर, अ नैरो एंगल ऑन गोनियोस्कोपी, यू ऑल्सो हैव अ हाई IOP. प्रेशर बढ़ गया है, पेशेंट को सिम्टम्स आ रहे हैं. सो यू कैन जस्ट से दैट दिस मे बी ऑल्सो अ सब अक्यूट स्टेज ऑफ द ओल्डर क्लासिफिकेशन. जो पहले सब अक्यूट स्टेज में बात करा था, यू कैन नाउ से इट इज़ अ प्राइमरी एंगल क्लोजर. आई होप यू गेट दैट व्हाट आई एम ट्राइंग टू से. ओके, नाउ ग्लोकोमा विल बी only told when you have optic nerve change and your visual field defect, that is the chronic stage. तो दोस्तों अब इसमें पढ़ना एक और चीज़ है कि अब करना क्या है. सपोज कीजिए पेशेंट को ये है, सपोज कीजिए आपने आज गोनियोस्कोपी करी तो पेशेंट के नैरो एंगल है. सपोज देयर आर नैरो एंगल्स, यू डन अ गोनियोस्कोपी टू द पेशेंट. नाउ व्हाट टू डू? अब क्या करें? हो सकता है कल को उसको एंगल क्लोजर ग्लोकोमा अटैक हो जाए. मे बी शी लैंड अप इन अ स्टेज ऑफ एंगल क्लोजर ग्लोकोमा अटैक. सो व्हाट टू डू? नाउ टू डू इज टू ट्रीट. हाउ टू ट्रीट? यू डू अ प्रोफाइलेक्टिक PI. Understood? So this is an important topic. For this and this you need to treat the patient. Don't wait for the patient land up in a stage of angle closure glaucoma attack. Acute congestive glaucoma नहीं होना चाहिए, ठीक है. So इन दोनों को ही treat करना है. We have to treat this as well. We have to treat this as well. All right. Now let's quickly jump upon to angle closure glaucoma attack management. So I'm sure you all know angle acute primary angle closure को treat कैसे करना है. So when you have a very high IOP, which is the first drug to be given, you all know it's mannitol, isn't it? Mannitol IV. We also have to start patient on glycerol, oral glycerol. If patient is non-diabetic, acetazolamide 2 tablets together will be given. Afterwards the patient will be happy, cornea clear हो गया, patient का vision अच्छा हो गया, pain कम हो गया. but अब क्या करो? So now you will start giving cholinergic drug. Why? Because pilocarpine will produce meiosis, and when there is a meiosis, it will pull the iris from the trabecular meshwork, so your attack will be broken. ठीक है बच्चे, this is important. Pilocarpine will be only given when your pressure is reduced to a certain extent. Otherwise pilocarpine will not work because the iris sphincter muscle is ischemic. आपकी जो आइरिस मसल थी वो इश्किमिक हो गई है, वो काम ही नहीं करेगा, वो कंट्रैक्ट ही नहीं करेगा. सो फर्स्ट डिक्रीज द IOP, make the sphincter muscle better to react, and then you start with pilocarpine. And the final thing will be do a peripheral iridotomy of both eye. So guys, what is the rationale of doing a peripheral iridotomy? Why are we making a hole in the peripheral part of the iris? Why? So what is the rationale? Let us try to understand this. So it is said that if there is a block here, let it be. अगर ब्लॉक यहाँ होता है तो होने दो. हम क्या कर रहे हैं? वी आर मेकिंग अ न्यू चैनल ऑफ ड्रेनेज ऑफ एक्वस by creating a new opening. So this is the rationale of doing a peripheral iridotomy. But friends, remember, this only helps when you have less number of synechiae. If the synecdoche are very very high, you can do two other procedures. The next is peripheral laser iridoplasty, where we are using argon laser mainly. And what are we doing? We are putting multiple spots on the peripheral part of the iris. So guys, these spots what you have placed here, these spots will lead to contraction of the iris and trabecular meshwork at these places, but they will open the in between trabecular meshwork spaces. जहाँ जहाँ लेज़र मारा है वहाँ वहाँ कंट्रैक्शन हो गई, बट बाजू के जो एरिया है वो खुल गए. ठीक है बच्चे. सो दिस इज द mechanism of peripheral iridoplasty. We can do it where synecdoche are more, where PI does not work. ठीक है. The next one and the last resort is you can do the surgery as well if you think that synecdoche are more and none of them are helping. So basically in trabeculectomy you will be cutting out a part of trabecular meshwork surgically under the partial thickness scleral flap. ठीक है. ये trabeculectomy last resort होता है हमारे पास. Okay. So this is the final picture of trabeculectomy. Another picture question for you all. You see this is the surgical cutting of the iris. ठीक है. लेज़र का कट नहीं किया. दिस इज सर्जिकल कटिंग ऑफ द आइरिस. ओके. एंड दिस इज द ट्रेबिक्युलेक्टमी ब्लेब. ठीक है बच्चे. हेयर यू हैव अ कलेक्शन ऑफ द एक्वस ह्यूमर. इट इज बीइंग फिल्टर्ड ऑन डेली बेसिस. ओके. सो दिस इज योर ट्रेबिक्युलेक्टमी ब्लेब. Now guys, one very important question. Last year you had a question on this topic. What was Vogt's triad? So Vogt's triad is suggestive of a past attack of angle closure glaucoma. मतलब suppose there is a patient who has an angle closure glaucoma attack today, okay, and I see the patient again after 3 years, after 5 years. So I'll have 3 kind of signs here as the classical triad of Vogt's. तो मेरे को क्या दिखेगा उसकी आई में? I will see pig. What is pig here? So P is pigments on the cornea scattered, right? What is I here? I is iris atrophy. Iris will become thin, atrophic. And the very important is G. What is G? Glaucoma flecken. Remember, this is very important. A past attack of angle closure glaucoma. Now again friends, I want that question to be discussed again. ठीक है ना. एक बार question फिर से discuss करते हैं. क्या हम बता पाएंगे क्या? So friends, we have the risk factors. We have a 50-year-old female complaining with headache, half of head is aching, there's a heaviness, and she see colored halos again, है ना. फिर वो बोलती है कि मूवी थिएटर में जाती है तब ऐसा होता है. मूवी थिएटर में आई नो द रिस्क फैक्टर्स, येस. एंड नाउ आई ऑल्सो नो दैट शी इज़ having a hypermetropic refractive error. She has a high presbyopia as well. Now his IOP is also slightly high. She may not be symptomatic at 24 IOP, but definitely her pressure is on the higher side. तो अब मैं क्या करूं बताओ. अब मैं सबसे पहले गुनियोस्कोपी करके देखूंगी और मैं साथ ही में YAG PI भी करके दूंगी. Yes, so I will do YAG PI of both the eyes. There's hardly any role of anti-glaucoma drugs. Why? Because it's a temporary stage. You ultimately have to do a PI only. ठीक है बेटा. Visual field analysis not much role here in this stage because we know it's a subacute stage. It's not a chronic stage. And treat her for migraine. No, it's not migraine. Though it resembles migraine very closely, but it is not a migraine. ठीक है. Now friends, with this a question. So अब ये आप पढ़ो और आप ये बताओ. So I've just changed this question a little. ठीक है. ये क्वेश्चन पढ़ते हैं बच्चे. सो अब हमारी थोड़ी सी यंगर फीमेल है, बट स्टिल शी इज़ अ मिडिल एजड फीमेल. सो देयर इज़ अ 45-year-old फीमेल एंड शी हैज़ अ रिफ्रैक्टिव एरर अगेन. ठीक है ना. उसको रिफ्रैक्टिव एरर है. क्या है उसको बेटा? फिर से हाइपरमेट्रोपिया है ना. देयर इज़ अगेन अ हाइपरमेट्रोपिया. नाउ अगेन शी हैज़ कलर्ड हेलोज. अब वो मूवी थिएटर देखने गई है, फिर से हेडेक हो गया, पेन हो गया. अब आपने चेक किया, you saw pressure is 22, है ना, 21, which is almost normal. So we saw that pressure is almost normal. Gonioscopy has a narrow angle. Now what should be the next step? अब आप इसका आंसर बताओ. अब क्या करेंगे? So what do you think? Which stage is this? So what I have twisted here, I have given you a normal IOP. हाँ जी. तो आप बताओ कौन सी स्टेज हुई है बेटा? What do you think? Which stage is this? I want answers from you. Which stage is this? This is a primary angle closure suspect or primary angle closure or primary angle closure glaucoma. और acute primary angle closure. So there is a difference. अब इन चारों में से आप बताओ ये क्या है? Anyone? Which stage is this? So guys, I have just told you there's hardly any role of visual field analysis here. It's an angle closure. Yes or no? We have a normal IOP, but she's developing a primary angle closure attack, subacute attacks. Yes or no? So there's hardly any role of visual field analysis. What do you do? What do you do? Gonioscopy हो गई, अब क्या करोगे? Guys, the answer is again YAG PI of both eyes. That's what I want to tell you. अभी हमने पढ़ा ना, देखो, I've told you the classification. What is that AO classification? Guys, what was that classification? So the classification said, कहाँ है? हाँ जी, the classification said that this one, it's a gonioscopic classification, and if you see the angles are narrow, it's an indication of treatment. मैंने ये बताया ना बच्चे, you have to treat this patient also, you have to treat this patient. Okay, and how to treat? You will treat it by YAG PI. In angle closure, especially the subacute stages, we need not to do any visual field. It will not give you any information. Visual field तब कब देता है आपको investigation? कब देता है आपको findings? When almost your 40% ganglion cells are damaged. You know that? Visual field changes तब आते हैं जब 40%, almost 40% damage हो चुका है ganglion cells का. And do you think in this stage you will have a damage of ganglion cells? No, not at all. Am I clear, friends? This one? Are you able to understand, friends? What is the question here? So basically we have a patient who is a suspect. He is developing some kind of attacks, but presently when she is coming to me, the IOP is normal. We can't wait much. We must treat the patient. And how to treat? YAG PI of both eyes. Am I clear now? So guys, that's why I told you this clinical topic, primary angle closure, needs to be understood, because there is a change. You know what we read in books, it's very very different from what we do clinically in glaucoma. जो हम बुक्स में पढ़ते हैं, हम क्लिनिकली बहुत फ़र्क करते हैं बच्चे. द क्लासिफिकेशंस, हाउ टू डायग्नोज, देयर आर सम न्यू मोडालिटीज़ ऑफ डायग्नोसिस इन ग्लोकोमा. Okay, so very very different. Now is that clear? If there's any doubt, please write to me on the chat box. Okay, and I've given you a homework. I've asked you what are the 2 new investigations by which you can assess the anterior chamber depth. You can see the anterior chamber and you can study the anterior chamber. Okay friends? So that's all from my side, guys. If there's any doubt, or if you have any topic which you want to read from me, the next time you can write down to me. We'll prepare a clinical case and we'll discuss the topic thoroughly. Okay, I hope you enjoyed the lecture today, and the next session again somebody will come live and will interact with you. So do attend and prepare well. So best of luck from every